Hi there, everyone. My name is Jason Florin from College of DuPage, and today I'm very excited to be talking to you about this unique topic, which is psychedelics. And the title, of course, is LSD, Ketamine, and Ecstasy Oh My. So what I'm hoping to do today with these slides is to help give you some information in preparing counselors to talk about the next generation of medications, which might be very different than what we've seen before. So let's take a look at what's in store today. So we're going to be discussing psychedelics, that category of drugs, as medicine, and looking at how they're being used in some different therapeutic trials. Also, how will this impact our field? What effect is it going to have if the new class of medications involves different psychedelics? Also, what can we as counselors and trainers do to help prepare people who are in the field and prepare to work with our trainees going forward? So yes, it has been a long, strange trip for psychedelics. So LSD is one of our first psychedelics. It was synthesized in the 1930s by Swiss scientists. And all the way back to the 1950s, we were taking a look at LSD as a possible therapeutic, including for addiction treatment. Bill W. of Alcoholics Anonymous famously used LSD for several years in the late 1950s and early 60s. He thought it held tremendous promise for people to have spiritual awakenings and get in touch with a different side of their consciousness. Over time, however, LSD became associated with a kind of countercultural movement associated with the hippies of the 1960s. It developed as a kind of negative, pejorative connotation around LSD and psychedelics that were thought to be just for a very small portion of society. And over time, that negative reputation culminated in it being banned by the federal government when there were the new drug laws of the 1970s and when the DEA was established, and drug classification system that we have still today was established at this time as well. And so LSD and similar psychedelics and hallucinogens end up going under Category 1 and being considered illegal by federal purposes. However, over the last decade, really starting around 2010, the late 2000s, we've seen this kind of renaissance where researchers are getting interested in a lot of these psychedelics and believing that they hold promise for different therapeutic applications. And we're going to take a look at several of those today. Okay, so to get started with some of the specific drugs that we're going to be looking at, the first slide here takes a look at psilocybin, which you may have heard referred to as magic mushrooms. You can see in the upper left-hand corner a picture of someone holding those. So this is a hallucinogenic drug that has rather long-lasting, long-acting effects, typically from at least 6 up to 12 hours. Now, very much like LSD, this is placed on drug schedule 1, meaning that it has a high risk of abuse and there's currently no accepted medical uses. Although in the last, again, decade or so, there has been a shift in attitude by researchers and even by governmental agencies to at least giving some of these drugs a chance to go through trials and make them more available for research. And so that's why you're seeing this plethora of data and research that's starting to come out of some of these institutions. Some of the major research hubs in the United States, including UCLA, Johns Hopkins, they are starting to set up their own centers specifically for psychedelic research. And I'll actually talk about a study that Johns Hopkins recently did here in a minute. So even though this is on drug schedule 1, there's no accepted uses, we're starting to see more research. And of course, if there is some kind of approved medication that comes out of this, we'd have to revisit where this falls on the drug schedule. The main indication this is currently being targeted for is major depressive disorder. It's also going through some experimental kinds of trials to see if it could be effective for tobacco use disorder, maybe even alcohol use disorder. So there are multiple possible indications, but the big one right now is major depressive disorder. So I'll just mention 2 trials that have happened. So out at Imperial College in London, where quite a bit of research is also going on in psychedelic medicine, they did a series of phase 2 trials that included 59 patients. And what they did was they compared the use of psilocybin and treatment, like talk therapy, versus Lexapro, which is a very well-established antidepressant SSRI medication, and talk therapy. So those 2 groups were compared, and then they used different depression rating scales after. So the result of that trial was what's called non-inferiority for the treatment group, which was the psilocybin group. So they performed a little bit better than the Lexapro group, but it was not statistically significant. And so non-inferiority is still at least a partial success in clinical trials. It's saying that the treatment we tried is at least not worse, it's not less effective than the currently approved treatment. So then you have to start looking at other kinds of effects, whether there's other benefits or there's fewer side effects, whether it can be done in a shorter period of time. So are there other reasons that psilocybin would be a preferred treatment for depression versus something like Lexapro or another SSRI, or at least for certain patients possibly. So that would have to get more data, more research in order to move forward, but it's showing some success at least. The next one I wanted to talk about is Johns Hopkins. So Johns Hopkins, again, has their own center now where they're doing psychedelic research. And they did a study very recently. It just concluded at the end of 2020. And so they were looking at a group that used psilocybin to treat depression versus basically not even a placebo group, a group that didn't receive any treatment. And so there's quite a bit of data from that trial, but the final conclusion was that the results of the clinical trial demonstrated that psilocybin was very effective as far as producing a large, rapid, and sustained antidepressant effect among people with major depressive disorder. So that trial, I believe, had 24 participants, so it's fairly small scale. It wasn't a clinically registered trial with the FDA. They're not using it to try and get a drug or medication approved. They're just trying to get some research information. But it backs up other studies of the same kind and same scope that suggests that this could be a very effective way to treat depression. Some of the questions we're going to have to look at are, how much does somebody need? How long do they take it for? And how durable are those effects? But those are all things that are being looked at. This is kind of a side note, just I found interesting in looking at the Johns Hopkins study. They provide a lot of information about how they set this up and how they do it. Somebody's kind of prepped with a counselor as far as what these sessions are going to be like. They did 2 separate sessions using psilocybin. And then they're basically kept at a clinic all day. They're in a room with 2 different kind of observers or people who are there to support them, make sure everything's okay. They wear an eye cover or mask so they can't see anything. And then they put on headphones that actually play music for them. And so in the addendums to this study, Johns Hopkins has the playlist, and I don't know why, I just found it interesting, but you can see it online. It's an 8-hour playlist, and participants primarily are listening to classical music during this time, things like Vivaldi, Bach, Mozart, Brahms, etc., as well as a couple of contemporary artists like Enya, and I think Louis Armstrong, What a Wonderful World, was also included on there. So just kind of a random thing, but what an interesting job it would be to be the person assigned to develop an 8-hour playlist for somebody who's going through a psilocybin experiment. The next one we're looking at is ketamine. So ketamine is actually approved for some limited uses as an anesthetic. That's how it was developed in the 1960s. It has anesthetic and analgesic properties. At higher doses, which is how it's used as a club drug and recreational drug, it can become dissociative for people. There's a term called falling into a K-hole, where you actually kind of lose your sense of identity and feel like you're disconnected from your body. So it can cause significant perceptual disturbances at higher doses. So an important point to note here is that dose sensitivity is so critical when it comes to these different drugs. With certain drugs like fentanyl, there's a very fine line between a therapeutic dose and a fatal dose. Also, with a lot of these drugs we're talking about, the dose will create very different effects. It can be therapeutic at a certain level, or it can be very dangerous at a different level. So the indications that they're looking at right now for ketamine are treatment-resistant depression and possibly decreasing suicidality. As I mentioned, this is an approved drug right now. So current drug schedule is 3, so very different than those that are sitting on drug schedule 1. Ketamine would be a much easier drug to research and work with because the federal government has this on schedule 3. So a couple of years ago, Janssen Pharmaceuticals, which is part of Johnson & Johnson, was doing studies on S-ketamine, which is very closely chemically related to ketamine. And that medication has now been approved under the name Spravato as a nasal spray. They've also done some trials and can use ketamine as an injectable IV in office under a doctor's supervision for this same treatment. So this is typically for people who have used other medications and tried other paths to treat depression but have not been successful. But a lot of the people on ketamine in the trials and now in real world results are showing rapid reduction in depression symptoms and especially in suicidality. So it's shown quite a bit of efficacy in that area. And it will be interesting to see over time if that continues to be an effective medication. But that is one that is actually approved and available already. On this slide, we're looking at a graph of clinical data. This is a study that was done after ketamine had already been approved as a depression treatment. And this is taking a look at 2 different groups. So one group, which you can see on the orange line, is the 6-ketamine group. So that group was given 6 doses of ketamine over a period of 12 days, so roughly every other day. The group shown on the blue line was given doses of Versed, which is a benzodiazepine, for each of the first 5 sessions, and then on the 6th session they were also given ketamine. So the researchers here were trying to figure out what are the intervals, how often should we be dosing people with ketamine, over what period of time, how long are we talking about is reasonable, because those are some of the issues we still need to figure out as far as treating depression with ketamine. So they're using a scale here called the Montgomery-Åsberg Depression Rating Scale. And what they're doing, you'll see for each infusion there's 6 infusions. So for each one, they're asking the person 1 hour into the infusion to fill out this scale, and then they're asking them to fill it out 24 hours later. They get a day off, and then they come back in and they get the infusion again, and they do that 6 different times. So it's interesting, both groups show significant improvement at 24 hours after their first infusion. Actually, they both come down right around to that same point. So on this scale, higher points are more indicative of severe depression. You want a lower score. And so there's a pretty strong correlation in how they move throughout those first few days. There is some separation after a few infusions where the ketamine group is scoring a little bit lower on this scale. However, it doesn't reach clinical significance until 24 hours after the 4th infusion. As you move to the right side of the graph, you can see a little more separation. The average score there for the ketamine group in orange is about 14, whereas with the Versed group, they're closer to about 20 on this scale. That separation gets even more pronounced at the 5th infusion. And then at the 6th infusion, what's interesting is both groups are getting ketamine. So the Versed group is now switching to ketamine. They're not aware of that, but they're getting ketamine at that point. So we see a pretty significant decrease in that group's score. actually to lower than the initial ketamine group score, which was 20 after the first dose of ketamine. And so at that point, even though the 6 ketamine group was lower on this scale, closer to 11 or a 12, whereas the Versed group was about a 15, it did not reach clinical significance or statistical significance. So there is something going on with ketamine, that it's affecting person's neurochemistry in a way that it's actually decreasing depression symptoms fairly rapidly after administration of the drug. That's kind of the way it's designed, especially to reduce suicidal thoughts. But as far as how long you should take it, how many episodes or treatments you should have, those are still kind of questions that are being worked out. So this is just some interesting information, I think, showing that there is definitely some effect of using ketamine, but there's more information that needs to be determined. I just wanted to give you a quick present here, and that present with this picture is the release of a little bit of oxytocin. So when our brains see something like this kind of a picture that we can relate to on this kind of human emotional level, frequently we will experience the release of oxytocin in our brains. And we'll talk about how that connects to our next slide. So here we're talking about the drug MDMA, also referred to as ecstasy or Molly. So one of the neurotransmitters that's associated with MDMA is oxytocin. We'll talk a little bit about that. It's also associated with rapid release of serotonin. It creates significant motor stimulation. It does have some hallucinogenic properties. It also has properties of entactogens, meaning that it's an empathy-based kind of medication. And so that's where the oxytocin quite possibly comes in. People using MDMA report much higher levels of empathy. As recently as the 1980s, some family therapists were using MDMA as part of their practice to work with couples because they found that it significantly increased empathy among the couples that they were working with. Eventually, though, this drug also fell on Schedule 1, and that's essentially when any legal use stopped, and a lot of the research stopped as well. It is being looked at right now for PTSD, post-traumatic stress disorder, and it's shown very good results in trials. We'll look at that data in just a second. Right now they've completed one phase 3 trial, and I've got the link for that there. They're comparing it to talk therapy alone, so MDMA plus talk therapy versus talk therapy alone in treating PTSD. And so if we look at that, what we can see is that they have different outcomes from this phase 3 trial, and they're doing a second one to confirm this data. And from that, which should be completed in the next 12 to 18 months, probably by the end of 2022 or early 2023, there's a good chance they will be applying for FDA approval to use this as a medication to treat PTSD, if those trials continue to be successful. So if you look at the chart there, you'll see that for people using MDMA in addition to talk therapy, 88% showed a meaningful reduction in their PTSD symptoms. 67% no longer met the diagnostic criteria for PTSD after 18 weeks, so about 4 months. Those in the talk therapy only group showed a 60% reduction in symptoms, and about 1/3 were remission, where they did not meet the criteria any longer for PTSD. So the results were quite a bit better in the MDMA group. There would be certainly a lot of questions about side effects for the medication. You know, were there any side effects in that group? How long was the benefit? How durable is that? So those are all things that will be looked at. But this trial is pretty far along, and if there's a second phase 3 trial that confirms this data, there's a decent chance they could get FDA approval for this. This slide just shows some other drugs that are under investigation or at least being considered. So dimethyltryptamine, or DMT, there was a book written about this called The Spirit Molecule. And there's quite a bit of information out there, videos if you're interested in looking at that. People have had kind of unique experiences with DMT, and it's kind of interesting to hear those experiences. Some of the treatments they're looking at are as a short-term, rapid, kind of 30-minute psychoactive experience as a depression treatment, where you might do a few sessions of that length in addition to therapy. But rather than some of the other hallucinogens where the experience can last many, many hours, this would be a much more rapid experience because they can get it out of your system fairly quickly. So that would be interesting to see. That's fairly preliminary, but something that's being explored. They're also looking at DMT as a possible treatment for those who have experienced a stroke, in helping them recover and rebuild some of their neurological connections more quickly. Ibogaine is one you may have heard of. It is not legal in the United States, but it has been used for opioid withdrawal as well as longer term for opioid use disorder. In some African countries, there's ritualistic use of Ibogaine. There are treatment centers currently operating in several parts of the world. Canada has a few, and they're looking to actually expand this as a opioid withdrawal treatment in Canada. There's some centers in Mexico as well as in Europe. So maybe you've encountered somebody who's traveled to get this treatment, or maybe they've taken a family member overseas or to Canada to try to get this treatment, which also is a hallucinogenic experience. But a lot of people who use it afterwards report no withdrawal symptoms, report no craving for heroin or whatever opioid they were using. So it is kind of interesting to see. But again, in the United States, this is not really being explored, but it is out there. Ayahuasca is another one. People have tried for opioid withdrawal. LSD, which was mentioned earlier, is now being looked at as a possible treatment for alcohol use disorder, as well as anxiety, particularly for those who are experiencing terminal illness. And you can hear a lot of self-reports of people whose fear and anxiety associated with death and experiencing just the pain and emotional struggle of those terminal illnesses has been greatly lessened by their use of LSD. So let's talk for a couple minutes about how this affects our field in addictions. So obviously, a lot of these are touchy subjects for us, and we may even be a little bit uncomfortable discussing them because we wonder what the implications are. Are we normalizing drug use? You know, recently, over the past decade or two, the push to get cannabis legal has largely been successful and continues throughout the United States. The kind of stigma that many of us may have grown up with and that we're used to around cannabis use is quickly fading, is quickly reducing. The perception about the dangers of marijuana use are much less than they've been in the past, and usage rates are certainly higher than they were. Whether that's a good thing or a bad thing is probably a different discussion, but it ties into this topic because in some ways maybe it feels like we are entering this era where drug use is more normalized across the board. Another question is whether psychedelics will come back more in vogue. Will they be more commonly and widespread? Will we see more common and widespread use of them? Also, could this actually lead to better outcomes in some of our treatments? Maybe there is some promise here for people who are experiencing co-occurring disorders, people who haven't been successful treating their depression or treating their opioid use disorder, for example. Right now, the opioid maintenance therapy that we offer in the form of Suboxone and methadone isn't effective for everyone and can come with its own concerns as a replacement therapy, essentially. So if there was a way to use a medication for a short period of time to help somebody withdraw and reduce their cravings, maybe there could be some benefit there. I at least want to keep an open mind about some of these things and continue to look at the research. I know for many years we've been hearing, well, this medication or this drug will kind of be the cure-all and it will, get rid of all these things. I don't believe we'll ever get to that point that there's one drug or one medication or anything like that that's going to be the panacea for everything when it comes to substance use disorder and when it comes to mental illness. However, if there are effective treatments out there, I've always told students and other people I work with in the field, regardless of my own philosophical bent, at the end of the day, I want to do what works for the client. And if it's effective for a number of clients, I at least need to keep an open mind about it. So as counselors and as trainers, what should we do? I think number one, we should be knowledgeable. We should be aware of this research. We should study up on it. We should keep an eye on it and just take in the information, be aware of what's out there and the data that's available. I think we also need to be aware that clients, some of the clients we work with are going to try these medications and try these drugs with or without medical oversight. So some of them might do them as part of clinical trials. Some of them might be prescribed these medications like ketamine at some point. And some people may self-medicate and try these on their own. So that's, I think, always been part of our experience in the field, is that we listen to clients' stories and we don't judge those stories. We just try to help them with their next steps. So just being aware that these are going to be used. And then to be willing to have those conversations with clients in a non-judgmental way, I think is a hugely important step and is a good way for counselors to get additional information about what's happening and what's being tried. When I was more actively working in the field, that was a great source of information. As clients who were new to treatment, they were the ones who knew what was happening, long before you hear about it in the news or in a presentation. They're on the front lines, very aware of what's out there. So again, part of that is being open-minded and willing to inform ourselves about what's happening without making a judgment, but also being open to what helps our clients and can be beneficial to the field. I have a few resources and references here for you to check out if you want additional information. Some of these are linked to different videos or articles if you're interested. There is a ton of research out there right now in psychedelics. The group called MAPS, the Multidisciplinary Association for Psychedelic Studies, has a website, maps.org. It's a great starting point if you're interested in this. I do think this is getting a lot more scientific and academic credibility, and I think that's going to continue. The research is certainly going to continue, so we can contribute to that conversation and we can be an important voice as well. Thank you for watching and listening to this presentation. I hope you got something out of it, and I'm always happy to talk more about it with you in the future. So take care.